Welcome to this video on the anatomy of asphyxia, exploring the pathway from cellular hypoxia to the resulting forensic evidence.
Asphyxia is a pathophysiological mode of dying, not a singular cause of death. It involves two simultaneous failures: oxygen deprivation, or hypoxia, and the inability to eliminate carbon dioxide, known as hypercapnia. This mechanism rapidly leads to unconsciousness and death.
The brain is extremely vulnerable to oxygen deprivation, consuming 20% of all available oxygen despite its small size. Neurons in the cerebral cortex can die within 3 to 7 minutes of complete oxygen deprivation, leading to irreversible damage. Interestingly, the heart is more resilient than the brain. Stoppage of vital functions is fundamentally driven by tissue anoxia. Gordon's 4 typologies of anoxia include anoxic anoxia, where oxygen cannot reach the blood; anemic anoxia, with reduced oxygen-carrying capacity; stagnant anoxia, caused by impaired circulation; and histotoxic anoxia, where cellular enzymes are blocked from utilizing oxygen. The 7 classifications of asphyxia describe external and internal mechanisms that precipitate anoxic anoxia. These include mechanical, pathological, toxic, environmental, traumatic, postural, and iatrogenic causes. External and physical triggers of asphyxia include mechanical blockage of air passages, environmental factors like enclosed spaces or high altitude, traumatic chest fixation, and postural positioning that impairs breathing or venous return. Internal and chemical triggers are pathological, where disease prevents oxygen entry; toxic, where substances prevent oxygen use, such as carbon monoxide or cyanide; and iatrogenic, associated with complications during medical anesthesia. Asphyxia initiates a vicious cycle in the circulatory system. Starting with deficient oxygenation in the lungs, it progresses through reduced oxygen tension, capillary dilation and stasis, congestion of organs, and diminished venous return, driving the engine of death. The clinical event of asphyxiation rapidly unfolds in 3 stages over a fatal 3 to 5 minute window. Stage 1 is dyspnea. Stage 2 is convulsions, leading to loss of consciousness. And Stage 3 is exhaustion, resulting in paralysis of the respiratory center and death. Tardieu spots, or petechial hemorrhages, are a striking visual evidence of capillary collapse. They are caused by raised venous pressure due to impaired venous return and increased capillary permeability. They commonly appear above the level of compression, externally on the face and conjunctivae, and internally beneath the pleura and pericardium. The classic asphyxial triad of forensic evidence consists of cyanosis, petechiae, and visceral congestion. These findings are all due to raised venous pressure and obstructed venous return, not a specific asphyxial disease state. External post-mortem appearances on the autopsy table include deep lividity, facial congestion, ocular signs like prominent eyes, and oral and extremity signs such as a swollen tongue and bluish fingernails. Frothy, bloody mucus may also escape from the mouth and nose. Internal post-mortem appearances include blood that is unusually dark and fluid. The respiratory tract, lungs, and trachea are congested. Internal Tardieu spots are visible beneath the pleura and pericardium. Widespread, intense visceral congestion is also present in internal organs. Further internal appearances show visceral engorgement and cerebral edema. Lung weight indicates the heart's final struggle. Light lungs suggest sudden cardiac arrest, while heavy lungs indicate the heart continued to beat after respiration ceased, causing massive pulmonary edema. In summary, the pathway of asphyxia begins with a cellular trigger, such as Gordon's 4 anoxias, leading to a physiological collapse in the form of the vicious cycle and 3 clinical stages. This ultimately results in the forensic evidence of the classic triad: cyanosis, petechiae, and visceral congestion.